Bordetella pertussis, right? So this is the bacterium that causes whooping cough. We briefly touched on the major stages, which are the important part of this this particular disease, is that there are three major stages to the disease progress. One being the catarrhal stage, which is the inflammation. This is going to look mainly like a basic cold, upper respiratory, which then quickly switches over to the proximal stage, which is going to be the stage that gives the name to the actual disease of whooping cough, where we have very strong coughing, very difficult for the patient to gain their breath, and then ultimately this whooping sound that comes from when they do catch their breath. And then it goes into convalescent stage, which is a non-contagious stage. The contagious stage is the proximal stage, and that's why that violent coughing, the bacteria has evolved to utilize that strategy to try to spread itself.
What were the three stages? You said proximal?
Catarrhal, proximal, and convalescent. All right, so the causative agent is a gram-negative rod, so it's a bacteria. Sensitive to light, it dries out pretty quick and dies pretty quickly outside the host, which is kind of different for bacteria. Again, we'll find exceptions along the way for everything, but traditionally we think of bacteria being pretty good at surviving on their own outside the body, where viruses tend not to. Well, here's an example of a bacteria that doesn't survive very well outside the body. That's probably why it has evolved to have that very strong cough reflex to try to force itself as quickly to the next host. Now, pathogenesis, cells are inhaled. It is a respiratory chapter, so again, when you're studying, don't think there's any different way. All these are inhaled. Attaches to the cells. Again, you're going to attach to the cells that they are selected for. So in this case, it's the ciliated cells of the respiratory epithelium, so everything down your trachea. There's a pili called the filamentous hemagglutinin pili and a pertussis toxin. These are the two major parts that cause this disease to have its pathogenesis. So yet again, just like we've seen with diphtheria, this is another toxin bacteria. So pathogenesis increasing, you get the ciliated action of the mucociliary escalator has been shut down because the bacteria is infecting and killing those ciliated cells, so the escalator can't work. Therefore, you're going to get increased mucus production. Mucus is going to start filling up in the lungs, which is going to cause the coughing sensation. Coughing is a reflex to try to pull up any mucus up out of the lungs that may be in there. Sometimes it gets so bad that we actually get collapsed lung situations. Again, think about the fact that most people that get whooping cough are infants, right? If you get it as an adult, it's a pretty minor disease. In infants, it's an extraordinarily fatal disease, can be. And so dealing with infants with collapsed lungs, and all these other problems, are very, very difficult. Spasms, partial mucus plugging lets air in but doesn't allow it to escape. And the chief cause of death is pneumonia, because again, pertussis is causing all the damage to the trachea, to the ciliated cells, but it's ultimately the accumulation of that mucus, then that leads to pneumonia-like symptoms and secondary bacterial infections that are going to cause the death of the individual a lot of times. Epidemiology, highly contagious, spreads quickly via droplets. Most patients are going to be the most contagious during the earlier stages, and then, as I said, once you get to convalescent stage, it's not an issue, something we don't even really recognize. And as we've already pointed out, classical disease of infants, right? This isn't something we tend to see in adults. Even in adults, they may not even get diagnosed as having whooping cough. They may just feel like they had a minor cold. And again, it's just the way that our immune system has already been built up. And even if you haven't had a vaccine to it, your immune system's already been built up enough that it's a lot better off than infants, right? We see this in chapters 14 and 15. All right. Incidence of disease is increasing. This is true. We're seeing whooping cough everywhere. One of my neighbors in Algiers Point, his triplets actually got it at 10 years old last year, even though they were vaccinated. So now there's a big question and a concern. Is there a new strain of Bordetella pertussis out there, or is this just some sort of coincidence with their particular immunology? But again, they acquired it from somebody at their school. And we're seeing this quite a bit more and more of diseases such as pertussis, measles is also a big one we're seeing on the rise, and even things like mumps, we're seeing on a rise in different pockets around the United States and the world. So better surveillance and diagnostics, this is important because when we see increases, we have to ask ourselves, do these increases because we're having a problem, an epidemic, or is it because our diagnostics have gotten better and something that may have been originally just a cold or flu, we now can say definitively that it's more to tell it. So that's going to drive the numbers up a little higher. And so we got to ask ourselves sometimes, is it the numbers? Is it the diagnostics? Or is this really a problem? And so better surveillance and diagnostics, that's why we're thinking that we're seeing a rise. That's why it's up there. Suboptimal vaccination strategies, again, not getting the optimal number of people vaccinated. We call that herd immunity or herd strategy. If I can get 90+% of people to be vaccinated, then the other 10 that aren't vaccinated are protected by the herd, essentially. And so when we say suboptimal vaccination, that means that we're not getting to that threshold that we need to ensure that even the non-vaccinated are going to have minimal chances of acquiring it, because these are passed person to person. So if you have a bunch of vaccinated people, there's no chance that they're going to acquire it in theory. And so therefore the ones that are unvaccinated are protected by the herd. Decreasing immunity and development of strains which the current vaccine is ineffective. I've added those in this year after the experience of my neighbors. The decreased immunity suggests that we're living longer lives, and therefore we don't truly understand the implications of what that does to the immune system. When does it actually start weaning? When do we start losing those memory cells? So that all could be part of why we're seeing an increase in pertussis. The last major outbreak, which we've had others, but this is the last major one, 2010 outbreak in Los Angeles, California area, mainly in Latino community, where they were living in very close proximity to each other, 10, 15 people in a house together, throughout the entire neighborhood. That theme keeps repeating itself. So you have very close proximity to each other and very little vaccine, probably none whatsoever in that immigrant community. And so it spread through like wildfire through their neighborhood in Los Angeles. And so we had quite a few cases come out of that. Treatment and prevention. So how do we treat it? Well, if we catch it early, we can't catch it late. We catch it when it's already in the whooping cough stage. There's not a whole lot we can do besides palliative care. But we catch it early enough, we can get it. Antibiotics will be helpful. So the catarrhal stage, that early stage, you give it antibiotics, we can wipe out that bacteria before it starts actually engaging in the pathogenesis, increasing its amount of toxin in the body, all these things. We can wipe it out early, great. But again, that's tricky because during this stage, people or the infant's not really showing much sign and symptom besides maybe a mild cold. But again, sometimes safer than sorry, go to antibiotics right away, because the antibiotics are going to be ineffective during that next stage, that paroxysmal stage. Again, the toxins are already in full effect, mucus is already developed. Antibiotics aren't what we need. We need to actually treat those symptoms versus trying to get rid of the bacteria at that time. Therefore, vaccination always important.
And then it said on here that there's 3 toxins it releases. So is it the pertussis toxin, the ACT, and the TCT one?
Yeah, so the biggest one is the pertussis toxin.
The PT is the most important.
Yeah. All right, so the next big one here, another one you've all heard of before, tuberculosis, and I was just having a conversation with somebody last night about this. It's a very common disease, right? It's actually declined quite a bit in industrialized nations such as ours because living standards have improved. But what we're seeing here in the last decade or better is we're starting to see more and more cases here in the United States, and it's coming from the quote-unquote couch surfers that tend to have a little bit lower hygiene standards, just crashing on each other's couches along the way, and that's giving rise actually to a very large subset of people that are now contracting tuberculosis from these lower subliving standards. So St. Louis, I was just hearing this from the doctor yesterday, St. Louis is having a major problem with tuberculosis in the traveling communities, and so we're starting to see that spread throughout the United States. So this is something we have to keep our eye on. I used to just tell this story, that this is something we don't necessarily worry about except for immigrants or people traveling in from other countries, but now we're starting to see it actually become a problem again here in the United States. So in 1985, the incidence also began to rise due to expanding AIDS epidemic. And again, tuberculosis tends to go hand in hand because it is a very slow growing bacteria. And so if you have very slow growing bacteria and the immune system's usually keeping it under check, having HIV, where it's basically knocking your immune system out, allows tuberculosis to manifest itself much quicker. And so we call these dual infected patients. We see quite regularly, especially in African patients, that they have both TB and HIV. If they come in for HIV, they might have TB also. So we actually test for both. CDC developed strategic plan for elimination, but that was a major flop. But we did get some decrease in the numbers. But at the end of the day, this is just a very difficult disease to try to even pretend to eradicate, because 1/3 of the world's population is infected. So you figure roughly 6-7 billion people on Earth. You're talking about 2 billion plus having tuberculosis. And then of those, about 2 million die. So the name of the bacterium, we've seen it a few times already this semester, Mycobacterium tuberculosis. Remember when we're talking about myco, that means that they have mycolic acid. That's that lipid instead of peptidoglycan. And that's what makes it also, gives it a lot of its pathogenicity too, because mycolic acid is a lot more difficult for the immune system to pick up. So it results in an asymptomatic lung infection. Asymptomatic means there's no symptoms, right? So in this case, when you first get acquired tuberculosis, you may go decades without ever having any signs and symptoms. There's really no way to know when you truly became infected. So what that occurs is the immune response is going to control it, but is unable to eliminate it because of that mycolic acid, because it grows so slowly. So that's going to yield what we call a latent tuberculosis infection, or LTBI. And that's where most of those 2 billion people that are infected with tuberculosis nationwide or worldwide, that's what they're in right now. They're actually in LTBI, they're latent tuberculosis. Now, through a series of different events, whether it be HIV switches to AIDS or some sort of other immunocompromising feature that happens in your life, age itself, where we have the weaning of the immune system, any sort of level where the immune system is no longer really controlling it as well as it used to, it'll switch from latent to active. And then active is going to be where we actually start seeing signs and symptoms in the patient. You start seeing slight fever, weight loss, night sweating, persistent cough, blood-soaked sputum because it's all in the lungs. And so there'll be a lot of blood when they're coughing up. We used to call this wasting disease. And the wasting disease is also tied to vampire legend of not truly understanding disease progression of the time. And the reason why they put stakes in the heart was that they would see one of their family members. Again, remember that back in the day, you might be living only in a 1 or 2 bedroom home with extended family. And they would see one of their family members get sick. And slowly but surely, they start losing weight. They start wasting away. This is why I call it wasting disease. Had no clue that it was caused by a bacterium at the time, because they didn't know bacteria existed. And so when they would bury their dead, when the family member finally died, maybe a month or 2 later, somebody else in the family would start getting sick and wasting away. And they believed it was a curse. They believed it was that other family member that had come back from the dead somehow and actually was taking out another family member. So they would actually go and stake the hearts or rip the heart out of the dead to ensure that they couldn't come back to life. So a lot of our vampire legend actually comes from tuberculosis and the stories that came out of people and their misunderstanding of what was really happening at the time. So I find these little things fascinating and look back at the history and go, well, there's a connection. But again, it's because of the fact that it's happened so quickly. Within just a couple months, you start losing major weight, you start having a lot of sweating, blood in your cough, and next thing you know, you're gone because you wasted away to nothing. So causative agent, we've already talked about. It's an acid fast. Remember, acid fast is just the way we stain mycolic acid. We have rod-shaped bacterium. It's a strict aerobe, and it has about 16-hour generation time versus at 20 to 30 minutes we see in traditional bacteria. So it's very, very slow compared to normal bacteria. Primarily affects the lungs, but then when it does switch over to active and it potentially gets into the bloodstream, it can go in advanced cases all the way to the nervous system. So we do see this disease potentially, going systemic. But again, that's not going to happen on a regular basis. Really going to be towards the end stage game stuff. So airborne cells, yet again, inhaled into the lungs. It gets into alveolar macrophages. So remember, we have macrophages that are residents to different parts of the body. Well, in this case, in the lungs, we have the alveolar macrophages. And so the alveolar macrophages are going to quickly engulf it, just like we've seen before, but they're unable to destroy it. The mycolic acid of the bacteria prevents the fusion of that phagosome lysosome that needs to happen inside the macrophage in order for it to ultimately destroy the bacteria. That mycolic acid prevents that fusion from happening. So now the bacteria is just trapped in the phagosome, and the macrophage has no way of getting rid of it. So now it's kind of like it's stuck in a catch-22. But ultimately, unfortunately, the macrophage is going to lose. Bacteria gets out of the macrophage's phagosome. It's still inside the cytoplasm. It starts replicating. So now the poor macrophage, that's job is to destroy these bacteria, is now being invaded and multiplied within. And that's going to cause more macrophages to get recruited. And ultimately, what's going to occur then is that, remember, the giant multinucleated cells, those are those giant cells when the macrophages become activated, they start increasing their numbers and getting really big. Well, then the last thing they're going to do is they're just going to form a granuloma. And a granuloma is just a walled off area. So you're keeping the bacteria walled off inside the lungs somewhere, basically trapped behind that wall. And that's where the infection ultimately just stays latent for decades. In some cases, if you catch it early, or you acquire it early, contracted early, you could be with a granuloma in your lungs for decades. It's when your immune system starts weaning, whether it be through immunocompromising situation or age, whatever it might be, that this wall starts to fall apart and the bacteria is not able to get out again and start replicating and turn active. So that's what you see here. It's a big, long spiel, but essentially that's all that's happening. You can go through step by step, but ultimately it gets out of the macrophage, and when it starts replicating again, the macrophage can't keep it under control. Then you get the active form of the disease. Essentially, all that damage that's happening from that massive inflammation response is causing the blood in the sputum, getting blood into the lungs, coughing that up. You start getting abscesses in the lungs. That granuloma ruptures, and you end up with this, what we call tuberculosis cavity, which is easy to identify in an X-ray.
And then the granulomas, they can be called tubercles, right?
Yeah, I mean they get different names for them, but granuloma is the generic name.
Are the TB cavities, like when you look at a person with TB on the X-ray, there's a little...
Yeah, the little spots that you see on that, they're able to identify. Yeah. So again, something that's pretty easy to diagnose in somebody that has active TB. Okay, so epidemiology. 15 million Americans. Even though I say that we don't really have a problem here in the United States, we've got roughly about 350 million people in the United States. 15 million are infected. A lot of those are going to be urban individuals because again, it's acquired through close proximity. It's also going to be people that tend to be elderly, again, because their immune system isn't. And we use non-white as a way to say Latinos mainly. It's going to be the immigrants coming into the United States, or people that are living in areas where they don't have really good access to health care. So foreign-born U.S. residents have a much higher incidence. Transmission, almost entirely respiratory. You only need about 10 or so, Mycobacterium to start the infection. And once you start going active, you get frequency of coughing, ventilation, crowding, immunodeficiency. All these are going to play a role in your chances of acquiring it if you end up having a lifestyle that ends up having you living in very proximity to other people, maybe not very high quality hygiene standards. There is a tuberculin kit test. If you've never had it done before, you probably will once you get into your fields. Essentially what it is a little bit of the antigen, not the bacteria. A little bit of the antigen is put underneath your skin, with a little fine pointed needle. And if your immune system has ever experienced tuberculosis, it will cause an inflammation response, much like you see here on this individual. It becomes red, becomes a little bit bumped out, and that tells us that you have been exposed. It does not tell us that you are currently contracted or currently have tuberculosis. It just tells us somewhere along the line, your immune system recognizes it and goes and attacks that little bit of antigen we put there. So this is kind of a tell for us if we need to do more testing to determine if you may have an active infection. And so what do we do if you have an active infection? Well, we've seen this before when we're going over chapter 20, that there's two major drugs that we use in combination. Those two drugs are used in combination because if we use them singularly, we sometimes get resistance. But putting two drugs in there makes it a lot harder for the bacteria to acquire resistance. There's also a vaccine that is available overseas. We do not use it here in the United States. It is a bovine version of tuberculosis, so a cow version of tuberculosis that has some cross-reactivity. And so it is useful for people that live in areas that it is a major problem, that they do give this vaccine. But here in the United States, we don't use that vaccine because we don't consider it to be a problem big enough to warrant a nationwide vaccination effort. So resistant strains often evolve again because this is a long-term antibiotic strategy you're put on. And so you may be on this antibiotic for months, if not up to a year or better. So compliance is a major issue. When we have compliance issues, sometimes we get resistance popping up. But of course, compliance is not the only reason why we get resistance. Sometimes it just happens, spontaneously. But what we're talking about here is compliance, where it's saying symptoms disappear, patient starts feeling better, they go off their drugs, or they go, doing them every now and then, they're not really complying well. Well, that's just a recipe for disaster for ultimately picking up resistance. So the next step after regular treatment, we have multi-drug resistant tuberculosis that's now popped up. And worst of all, we have an extensively drug-resistant tuberculosis. Difference, multi-drug resistant means that we still have a couple drugs out there we might be able to use, but they have high toxicity issues. So again, it's not going to be as nice of a medication to take as the original. And then extensively drug-resistant just says, we don't have any way of controlling this whatsoever. So this is the one we're most concerned about, basically becoming a global pandemic issue, is that this extensively drug-resistant TB ends up making its rounds around the world. We could all be in trouble. Next one, Legionnaire's disease, unknown until 1976. It got its name from the American Legion. The American Legion is one of these groups that formed of war veterans, and they have a national conference, just like many of these different organizations do. This year, in 1976, it happened to be in Philadelphia at a hotel. And the thing with American Legion members, well, they're a little older, right? Because they're veterans and whatnot. So they're going to be in their 40s, 50s, 60s, even older sometimes. And what occurred here was that the people that were attending this conference started becoming ill with pneumonia-like symptoms. And there was no way of knowing what the heck was going on. They transferred them to the hospitals. A couple of them died. Others, they weren't able to get an actual strain of bacteria to grow. They didn't know what it was that they were infected with. Signs and symptoms, pretty standard for cold or bad cold. Headache, muscle aches, high fever, confusion, and shaking are going to come along in the very later stages of it. But again, if you're having very high fever, you'll have chills usually and convulsions from that fever. Dry cough develops. Sometimes you get sputum and blood, but mainly dry. Shortness of breath is common. A lot of times you need to go on oxygen therapy. Again, we're dealing with elderly, for the most part, and so this is a big problem. Recovery is slow. It can last for weeks, fatigue-wise. Causative agent, after we were able to actually figure out what it was named Legionella pneumophilia. This is a gram-negative rod, so again, a bacteria, and it's a facultative intracellular parasite. It can survive pretty well outside of the body in fresh water. So how did this actually all come, and why is it all coming together there at that hotel? AC. Yep. So the AC unit, before we used copper. Nowadays we only hear about copper because people are always stealing people's copper from their ACs and whatnot. But why do we use copper? Well, it's a better conductor, but the biggest reason why is it's got natural antimicrobial properties. No bacteria can grow on copper. But back in the time, they were using steel. Steel, you get puddles of water up in the ventilation shaft, especially in high humidity of the summer. You get these puddles of water. This bacteria happens to survive quite well in fresh water. And then what happens when we turn those fans on to start pushing air around? Well, now you just aerosolize those bacteria, and everybody that's in the conference room is breathing them in, and they're getting sick and falling left and right. And so not only did we discover a new bacteria species out of this problem, we also discovered that switching over to copper was essential for AC units, for refrigeration units, anything that may potentially harbor water and has a potential of passing on to humans. All that's been switched over to copper because copper has a natural antimicrobial property to it. So high doses of erythromycin and rifampicin are going to be useful. So if we go over to the cephalosporins, remember those are the bacteria-derived first-gen antibiotics, where the penicillin ones are fungal-derived. And so this was a big deal, but ultimately we don't see this one very often. Occasionally we'll see pop-ups of it. It was really the key was the discovery and what that discovery led to in terms of better public health. All right, so the last part we're getting into in this chapter is going to be viral infection of the lower respiratory system. In this case, the RNA viruses are the most important. Remember, viruses come in two flavors. They either come in as DNA or RNA. And the RNA ones are the ones that are the biggest deal. And so the very first one there is flu. Flu is an RNA virus. We infect about 20% of the global population of humans every year when we go through flu season. There are three major types of flu virus, A, B, and C. A being the worst, B being still pretty bad, but not as bad as A, and then C being a minor importance. This also drives people's perceptions, right? If we have a type C going around the city, then you may get it, but not realize you had it. It may just be a minor cold-like symptoms because it's a very minor case of the flu. You may not even recognize that you had flu. You get type A, absolutely you're going to know it. You're going to be bedridden. So signs and symptoms, about 2-day incubation period, which is also part of the problem for urban legend, is that it's only a 2-day incubation period. So you go get a vaccine because one of your buddies at work or at school got sick and had the flu. You're like, oh shit, I'm gonna go get the vaccine right now. Well, you're already sick, right? You're already incubating. You're already incubating it because it was already passed on to you. You don't have signs and symptoms yet. But then, a lot of people go get their vaccine, and then the next day they're sick, and they're like, well, I got sick because I got the vaccine. No, that's not how it works. And so ultimately, this is a lot of what drives this, is that there is a 2-day incubation period, but the acute symptoms last upwards to a week, and that's where we start having problems, is that, the body, for the most part, can fight off the flu with the right care. But then, since it lasts so long, that then we have to worry about those secondary infections that come along the way. So influenza A is the biggest virus that we see, but unfortunately it mutates a lot. So the two things that we're looking for are the glycoproteins that are on the outside surface of the virus. And there's two that we look at. There's hemagglutinin and neuraminidase. These are just proteins. Neuraminidase is an enzyme, but again, it's something that we can visualize and understand which ones we're dealing with. And that's where they get their names H1N1 or H5N1 or whatever the particular, you hear those names get thrown around a lot every flu season. Which versions of the virus are we fighting? Well, it's going to be based off of which version of hemagglutinin and neuraminidase they're carrying. That tells us how pathogenic that particular virus might be that year. So some of the major ones that we've seen over time, I haven't updated to include last year's, but last year was sort of a pretty bad year too. Um, 1997 was the avian flu. Started out in birds and then moved its way over to humans. It mutates. And then the other one, swine flu, mutated from pig over to human. And that's usually the two ways that we see the mutations occurring in nature. Going all the way back to the major Spanish flu of 1918 was a swine flu also. So we tend to see them start out either swine or avian and then move over. Pathogenesis, nothing new here. You notice a lot of wordage here. Just think about it the same way as always. You got to breathe it in. It has to attach. When it attaches, it's going to get inside the cell. It's going to replicate inside the cell, kill that cell, and then spread on, just like all viruses do. Because it causes so much damage from killing all the different cells in your respiratory system, it can take upwards of 2 months, and some people to feel completely back to normal after going through a major flu breakout. So only a small percentage die, epidemiology, from flu, but it definitely is a miserable situation for them. One of the biggest problems also is going to be the cost associated with taking time off of work and cost loss of production time, which is a major contributor to global health. If everybody's sick at a major industry and have to all take time off, well, then that industry is not producing whatever it is it needs, causes all kinds of other backlogs. So when we think about the individual health of people, we also sometimes got to think about, well, what's the bigger global impact too. So when you see here, most deaths are actually from the bacterial infections. That's the secondary. Flu is virus. But again, because it's causing so much damage, the immune system can't keep up, and sometimes those bacterial infections can get in pretty easily. So most people are going to die of secondary infections, not the flu. Epidemics happen every year. So an epidemic is when a large portion of the nation gets sick. A pandemic is when a large portion of the world gets sick. So nation versus world, every year we have epidemics happen in flu. Sometimes they're minor, sometimes they're major, but it's a guarantee every year we're going to have a flu season. And then occasionally we'll have pandemics, and that's when there's a mutation that occurs where there is very little immunity around the world at all. That means like a huge portion of the population of the world has never experienced that particular combination of hemagglutinin and neuraminidase. Therefore, it ends up infecting a lot of people.
When's the last pandemic?
Well, that's the ones that we have. I would say last year was pretty bad. I haven't seen the numbers come out to see if it's
Worldwide.
worldwide. Pandemic was last year. Yeah, last year was a pretty bad year worldwide.
Really?
Yeah, I haven't seen that they actually labeled it a pandemic yet, but the biggest one that everybody always points back to is that 1918 Spanish flu one. That was a really, really bad one that caused a lot of death. Again, thinking back to 1918s, there wasn't a lot of medicine that we have available now, palliative care that we don't have available back then. But that was one of the biggest ones, killing 40 to 100 million people. That's pretty significant. The other ones that have always been fearful, the avian flu was a bad pandemic too. It started out over in China and made its way over to the United States, infecting people along the way also. So the two ways that the virus mutates, these are terminology that does not just apply to the flu. So this is just these are strategies that both viruses as well as eukaryotic cells, we see this quite regularly, when we look at mutation of DNA. But here's the two ways that we see mutations happening in the flu also. We have antigenetic drift versus shift. Antigenetic drift is just minor mutations in the hemagglutinin and neuraminidase. Sometimes it can be as small as just one single amino acid, but that change is responsible for the seasonal flus. Just one little change changes the way that, remember how specific the B and T cells are, that even that one little amino acid change is enough for it to misread that particular epitope sometimes. Now, if that shift or that drift is not significant and you got your flu vaccine last year, this is another thing we hear a lot is well, I got it last year, I didn't get the flu this year, so it's still working. Well, it could be, if the drift wasn't that bad and you still have some sort of immunity left over from that last year's flu shot, there's a potential. but you can never guarantee those things because you don't know until it's upon us. The other one is antigenetic shift. This is where there's going to be a major change in that hemagglutinin and neuraminidase. And when that occurs, that's when we get the pandemics happening, because there's been such a change or shift in the antigens that pretty much nobody worldwide has any sort of exposure to that before. So drift gives us our yearly changes in the flu. Shifts give us the major changes that ends up being a major problem throughout the world. As I already pointed out, Spanish flu is the biggest one. The treatment and prevention, a lot of the antivirals, we got Theraflu or whatever it is now that can be helpful, but again, it's not an end-all be-all. You have to take it within the first day or two of getting sick, or it's basically useless. But that would be like the antivirals that we're talking about, and vaccine strategies are always the best. Other than that, we have to basically just do palliative care and let the virus clear itself out. All right, next virus is respiratory syncytial virus, or RSV. This is mainly a childhood virus, but can also infect adults too. About 90,000 hospitalizations a year, 4,500 deaths. So that tells us that there's it's not incredibly fatal, but there is a large portion of people that do die. Incubation period, again, a few days. And that's always a problem, because that means that you're walking around potentially contagious and not knowing it. But everything else is pretty much straightforward in terms of what you'd expect out of a respiratory disease. But this is what actually causes croup. So this is something we see more in children. Manifests as a high-pitched cough and a lot of wheezing. And so a lot of times parents will say, oh, my kid has croup. Well, it's actually RSV or some other related virus. And so the people that's going to be mainly fatal for, again, is going to be the same that we see all the time: elderly, immunocompromised, very young. Causative agent is another RNA virus. It's a part of the family paramyxovirus. Again, the pathogenesis is the same as we've always seen before. You've got to get it in. It has to attach. Nothing new there. But then ultimately, if it causes enough damage, we're going to have pneumonia resulting in secondary infections, just like we see with all the other diseases we covered. It's epidemiology. It does have a season, and it tends to be late fall to late spring. And so what's happening during that time? The school year, right? So this is a school, because it does infect children, and it tends to be a virus that we see cycling through the schools on a regular basis. We'll see spikes in it, and then we'll see none for a little while. We might see another spike a couple months later, but it tends to follow through the school years. Treatment and prevention, nothing we can do except for trying to do palliative care, but we do have a monoclonal antibody that seems to be somewhat helpful, giving some sort of immunity to people. But again, not really all that great. It would be somebody that it tends to get RSV quite a bit. There is an opportunity here to help try to minimize that, but it's not something we're going to give out to everybody. It's just going to be for those special circumstances. Hantavirus, this is one that we're starting to see quite a bit coming up in the news. We actually had somebody die of this a couple of weeks ago, and so it made major rounds in the news to, scaring the hell out of people because nobody's ever heard of hantavirus, and hantavirus just sounds kind of cool in its own name, sounds kind of ominous, right? Very first outbreak was in 1993. We see it in the same area that we see Black Plague still, the actual disease that caused the Black Plague in the 1300s in Europe. Yersinia pestis, and we happen to see hantavirus in the same areas. The United States, it's in the Four Corners. That's where Colorado, New Mexico, Arizona, and Utah, I can't remember what the four, they actually make a perfect corner to their borders, and so you can go there and you can stand and put your hands on all four states at the same time. That region is where we tend to see hantavirus as well as Yersinia pestis. So what happens here is most victims are going to be young. They develop what looks like flu, and then they die within a couple of days. So they really truly understand. This goes back to the idea that having better diagnostics, we understand the disease is a little bit better. And so while this is not a new disease to nature, it's a new disease to us. That's only because we just got to the point where we understand it's something different. So it's caused by the hantavirus. It's closely related to one that we seen during the Korean Wars. But the signs and symptoms, again, as it already says, it looks like flu at first, but you're going to have muscle aches, a lot of pain in the back. You might start getting vomiting and diarrhea. Unproductive cough, shortness of breath, followed by shock, and then death. So it tells us that it's probably getting into the bloodstream and causing some sort of shock-like issues. The pathogenesis, you get it enters through inhalation of dust. This comes from a virus that is carried by rodents. And so this is going to be people that have like outbuildings or barns that aren't used very often, but may have an infestation of rats and whatnot. And you open up those barns, they're going to be basically, or like even a back shed that has been stagnant air in there for a long time. You open it up, start kicking dust around, you're breathing that in, and you get
Even like, I heard if a bat hits you, like if a bat comes in contact with you, you should go to the doctor immediately because something's wrong with the bat. If bats don't, I don't know, you said rats, it just made me think of this. Do you know anything about that?
bats in terms of, they carry rabies and there's actually some experience that they may be carrying other viruses too. So the fear is that, kind of contact, you're getting that direct exposure to that virus. But I think that's
usually,
bats not going to come at you because, but they're blind. So a lot of times they just run into you for no
just
apparent
acid.
reason.
yeah.
So I wouldn't necessarily think that seems like over the top,
Right.
but it could work.
And that makes sense with the barns and everything, like in the Southwest, like tons of dusty barns.
Mhm. Yeah.
They treat clean barns.
So there's like animals don't have their own like healthcare, like they don't have like just like random animals in the world. They don't have their own doctors or healthcare or anything. So why don't diseases kill them?
They do. I mean, they kill quite a significant, but they also develop symbiotic relationships, right? I mean, we got 10,000 different species of bacteria that live inside us, and they don't kill us. We've developed a relationship with them. That relationship with that virus may be the same in a rat, but when it gets into us, we haven't evolved with that virus, and so therefore it causes major damage to us. But inside that rat, it doesn't bother them at all. In that case, but there's also major diseases that take out animals all over the place. We actually have viral hunters out there looking for dead animals and trying to understand, what's wiping them out. All right, so did you have something too, Sean?
I was gonna say later in the section we read about fungi infection, like bat droppings in a cave.
Yeah.
And she was talking about that.
Yeah, there's that. We actually believe Ebola might be a link back to bat caves too in Africa. Yeah, we're still trying to hunt down the actual Ebola locations.
One last question is, so can some of these like lower respiratory, some of these viral infections be prevented if they treat some of like the upper respiratory? Because like I noticed how like some respiratory infection, like signs and symptoms are like strep throat, sinuses. So if they treat that, can that prevent like?
Well, that would make the assumption. I see where you're going with that. That makes the assumption that all infections are the same. Some of them are actually only lower respiratory. Like tuberculosis only gets into the lower bronchioles, and but some of them, yes, those upper respiratory ones that manifest and aren't treated, and they can eventually turn into a lower. Absolutely, so it's just having to make that diagnosis at the time per individual. So in this case, inflammatory response is going to be a big role because we see shock and death being one of the outcomes of hantavirus. The only way you're going into shock is if you have some sort of blood pressure issues, low blood pressure. Typically what that's caused by is the immune response. The immune response is dilating the blood vessels, allowing that seepage to happen to get over to the other side. If that happens systemically, then you're going to go into shock. And then that shock's going to lead to death. So it's not surprising. We see the inflammatory response being key to these viral antigens causing death. And having shock and death occurring in more than 40%, just because what I was just telling Amelia, is that, when you don't evolve with a virus, sometimes they go overboard and kill the patient pretty quickly. Ebola does the same thing. It's not a virus that we evolved with. our body doesn't know anything about it, and so sometimes it's a very quick death with these. So it's epidemiology, zoonosis. Zoonosis is the idea that it's carried also by animals, right? So animal and human zoonotic diseases. It's an emerging disease, which is terrifying. It means that we're seeing it more and more, and it's being diagnosed more and more. So again, is it because we're seeing more cases of it, or is it because we're better at diagnostics? That's a question that still has to be answered. We don't know, right? So we have to consider it an emerging disease till we figure that part out. We're finding it in countries all the way as far north as Canada, all the way down far south as Argentina. So that tells us that it's basically has a very large berth of environments it can survive in. But the one key there is what? Rats are found in all of those, right? So this is basically something that's being carried around. Treatment, no proven treatment. Disease is highly fatal. This is one of those BSL-4s, right? Going back to chapter 3. Hantavirus fits in that BSL-4 category, which is spacesuits essentially you're wearing, right, to work on it, because there's nothing you can do if you get sick besides Godspeed, right? There's nothing we can do for you. So what we can do is all going to be prevention-wise. If you do have one of these outbuildings, like she was just saying, you got to keep it clean. Again, it's easier said than done. I grew up on a farm where we got 7-8 different barns on different properties. The last thing you've got time and effort for is to clean those constantly. They're designed to be dirty. So it's really difficult to actually keep them clean. But you can do mouse proofing, having traps set, if you do notice problems, trying to minimize wearing respiratory gear if you are going to a building that hasn't been used in a while. It says here, use mops rather than brooms and vacuums. You think about a broom and a vacuum, what's it doing? Aerosolizing, right? You broom in, you're aerosolizing that dust. A mop is going to catch it in the hair versus, or in the mop, pieces versus the, pushing it around with a broom. All right, so now we switch over to fungal infections. And like I said, I don't really ask you a lot about fungal infections because they're not very fatal. And so even though it can be annoying for many people, most of the time they're not going to develop a fatal disease out of these fungal infections unless they have compromising features, elderly, young, some sort of other problem going on.
Earlier you said something about a lung abscess. Would an abscess just be anything that has bacteria?
Abscess is going to be essentially a hole.
Okay.
So it can be caused by bacteria, it can be caused by a toxin, it can be caused by bad chemical burns. So you get abscesses. So here you got symptoms are usually symptomatic and asymptomatic infections. So this is going to be pretty easy to treat. The fungal infections for the most part, but again, we're going to see a couple here that are important. So we got coccidiosis mycosis, very long-winded one. It's easier to just call it valley fever. Again, notice same area, right? Southwest United States, same place we see hantavirus. People exposed to dust and soil. Again, this is what bacteria, funguses, viruses, they all ride on dust. So when you're causing a big dust storm or causing dust to be pulled up, Southwest doesn't have a lot of water, so it's very dusty conditions out in those areas. So it makes sense that this is going to be a big problem. Only about 40% of people that contract it actually get symptoms. So again, it shows you that's pretty minor infection. Signs and symptoms are going to be flu-like, fever, cough, goes away on its own for the most part. But a very, very small percentage of that 40% are going to contract a chronic virus, a chronic version of it, where we're going to see a thickened wall, that essentially goes in endospore and causes inflammatory response on a regular basis. You might be perfectly healthy for a month or so, and then all of a sudden, for whatever reason, the fungus comes back out of its endospores and starts causing another inflammatory response. And that just keeps going over and over again until we can finally clear that infection out of the person. Treatment, again, antifungal treatments, pretty straightforward. Just monitoring, making sure that we got it cleared. Again, that's only going to be for those that get chronic. Those that get the acute version, they're just going to get better on their own for the most part. They may not even see a doctor. Histoplasmosis is another nasty one. It mimics tuberculosis. So this is one that may, at first, the patient may think they have tuberculosis, or even the healthcare providers may initially suggest that. But it's really only going to be serious, again, if people have immunodeficiency, just like most fungal infections. Signs and symptoms, again, notice most infections are asymptomatic. And again, fungal infection. But the rest of them are going to develop something similar to other respiratory diseases. They may get some mouth sores that show up, which is kind of novel. So that would be a tell. That would be a good symptom for a healthcare provider to notice and say, well, this is something different than what we may have thought. Causative agent, histoplasma capsulatum. I can never get some of these. Notice here, grows in soil, contaminated by bat and bird dung. So this is another example of one that is being passed on from animals. Gets inside us, it can grow inside the macrophage. That poor macrophage gets beat up quite a bit by some of these infections. Even though its main job is to wipe them out, again, it's a strategy game, right? There's a match happening here. There's some different examples there. Mold form produces macrocondylia, and the other one is going to be microcondylia. And that is just really looking at this right here. When we see them underneath the microscope, they're going to have these different shapes to them, and those are going to be ways that we identify, a pathologist would identify what's macro versus micro. Am I going to ask you a question about it? Don't worry about all the terminology underneath the fungals. Biggest thing I need you to know about the fungal infections that is really what we studied in chapter 20 was what is the structure that we go after. We go after something that's unique that we find in fungals that we don't find in other parts of our body because we're dealing with eukaryotes, right? So we have to find something that's specific that they have that we don't, and that's that ergosterol that's similar to peptidoglycan but found in fungal. So that's really what I want you to know from those here. If you're interested in these, or maybe you have family history or something, you're just interested, that's great, but don't spend a lot of time studying the fungal infections because there's a lot more important things to ask you about. Histoplasma, we already did that one. Again, nothing exciting here. I'm going to flip through these because I do want to get into chapter 22. So this is the last one there. So again, just kind of be familiar with the names, but again, don't get into a lot of the